So is my slide visible?
Yes, yes, doctor, your slide is visible and your sound is audible.
Okay. So good evening once again. Salam alaikum. Trigeminal neuralgia is a neuropathic pain of one or more branches of trigeminal nerve. Okay. So you can easily say it is most common facial pain in elderly population. So elderly population means generally after 40 years. So in 40 years and beyond, especially in women or female, this facial pain is one of the most common is the trigeminal neuralgia. Okay. So as I've mentioned in the slide also, trigeminal neuralgia causes severe, sharp, unilateral, superficial facial pain, and it is one of the worst pain that is experienced by the person. So there are few pain which is very much severe for especially for the male. One is trigeminal neuralgia, another is uretary colic, third one is fracture of any bone, and the fourth is the labor pain. So the and another one is the cluster headache. So these are the few clinical scenarios in which there is extreme amount of pain and this pain is usually so much severe that it decreases the quality of life. Um, for example, if somebody has trigeminal neuralgia, he will not be able to do his or her day-to-day activities like brushing teeth or eating food or simply washing the face or putting makeup. So these small daily activity will be very painful and very it causes severe pain in the patient. Thus it is also known as suicidal disease. So pain is so much that patient want to commit suicide because to get rid of pain. So it is such a severe kind of pain which is experienced by the patient. So if you see the history of trigeminal neuralgia, so trigeminal neuralgia has been with us since the beginning of mankind, and it was first described by Arterius in 1st century AD. And in his description, he has mentioned that for the treatment in past, they used to put snake venom or scorpion venom or even bee venom, or even they used to pour sulfuric acid over the face and even mercury and arsenic because in those times because of lack of knowledge of disease or because of lack of pathophysiology, various dangerous or shall I say inhumane treatment was done at that time, like putting pouring sulfuric acid over your face, which used to disfigure the patient. Okay, but in 1756, of a French physicist named as Nicolas André was the first one to describe the actual pathophysiology and describe the disease process. And since he was a French person, he named the disease as tic douloureux. So in French, this trigeminal neuralgia is also known as tic douloureux, which is known as painful facial spasm. So only in 1756 the actual pathophysiology and actual disease was described very beautifully. And the first treatment of trigeminal neuralgia started in 1902 with injection of alcohol in the trigeminal ganglia. And it may be surprising for all of us. Still now, in my part of world, I'm from Asia, and my country is not so developed. It is a developing country. So in some part of my country, in some parts of my country, especially in the border area or in hilly area, so people still use alcohol for treatment of trigeminal neuralgia. So it's been almost 200 years before alcohol was introduced first time, and still we are using alcohol till now also. And the first breakthrough came in the treatment of trigeminal neuralgia was in 1960 when carbamazepine was first introduced in the medical science. Okay, I'm sure Dr. Mahmood will again elaborate on this, but I have to say this that it's been almost 60 years or even 70 years since carbamazepine was first introduced in medical science. But till now, carbamazepine is the first choice of drug in the treatment of trigeminal neuralgia. So later on in 1965, Dr. Sweet did first radiofrequency lesioning of trigeminal ganglia. But what they experienced at that time was corneal reflex loss was very common in those patients who had undergone radiofrequency ablation of trigeminal neuralgia. So they another treatment for trigeminal neuralgia is going for percutaneous balloon inflation and causing mechanical destruction of the Gasserian ganglia or trigeminal ganglia. So it was first done in 1978, and later on people also started injecting glycerol in the trigeminal ganglia or Gasserian ganglia for the treatment of the disease. So, but if you see this slide, we are still using few of the old technique like alcohol injection in the place where medical treatment is not so much available. We are still using carbamazepine, which is the first choice of drug till now. And there are other drugs also like gabapentin, phenytoin, lamotrigine, or oxcarbazepine is also there. But having said that, carbamazepine is still the first choice of drug for anyone who is having trigeminal neuralgia. Okay, so if you see the anatomy of the trigeminal nerve, so trigeminal nerve, as we all know, it is the fifth cranial nerve, and it is a mixed nerve. So it has a sensory part as well as it has a motor part. Especially the mandibular division of the trigeminal nerve is a mixed nerve, but ophthalmic branch as well as maxillary branches are the sensory branches. So if you see this slide, the trigeminal nerve basically originates at the brainstem. So in the brainstem, the origin of the trigeminal neuralgia occurs, and as soon as it comes out from the brainstem, it goes into the petrous part of the temporal bone, where there is a cave which is known as Michel's cave. Okay, so the apex part of the petrous part of the temporal bone is a triangular shaped bone. So the apex of the this petrous part of the temporal bone is hollow, and it forms a Meckel cave. So once the trigeminal nerve goes into this cave, it swells up and it forms a ganglia, and this ganglia is known as Gasserian ganglia, and the other name for this is Gasser's ganglia, and the other common name is also, it is also known as semilunar ganglia, because if you see the shape of this ganglia, it is in the semilunar shape. So it is like this, it is like a crescentic shape or semilunar shape. Okay, so and if you see it, after the formation of ganglia, it has three branches. The first branch, we commonly know call it as a V1 branch. It is a ophthalmic branch of the trigeminal nerve, which is located in the superior medial aspect of the Michel's cave. The second branch is maxillary branch, which is purely sensory, and it is also, it comes out from the foramen rotundum of the base of the skull. The ophthalmic branch comes out through the superior orbital fissure, and it goes to the orbit. And the final third branch, which is located most inferior and most laterally, is mandibular division of the trigeminal nerve. This mandibular division is a mixed nerve, so it has a sensory supply as well as it has a motor supply as well. So for example, it supplies to the muscle of mastication, it also supplies to the temporalis muscle. So this is the basically the Gasserian ganglia and its branches. And if you see the boundary of this Michel's cave or Gasserian ganglia, in the medial aspect of this Gasserian ganglia is the cavernous sinus. So this red color vessel is the cavernous sinus. Okay, and the superior part of the this Gasserian ganglia is formed by the inferior surface of the temporal lobe of the brain. Okay, so here there is a temporal lobe of the brain. In the medial aspect, this is cavernous sinus, and in the posterior aspect of this gastric ganglia is the brain stem. Okay, so this is a very sensitive area. So when we are doing any intervention, you have to know what are the important structures surrounding the gastric ganglia, so that we should not basically cause any damage to these surrounding structures, especially the this brain stem. So when we are doing radio frequency ablation of the gastric ganglia, if we don't pay too much attention, we might our needle might go to the brain stem or to the midbrain and cause damage to the brain. So we have to be very careful while doing intervention in those patients who are having this severe trigeminal neuralgia. Okay, so if you see, this is the picture of the base of the skull, and there are few opening in the base of the skull, but the most prominent opening in the base of the skull is this foramen ovale. So there is a oval shaped foramen through which the mandibular division of the trigeminal nerve comes out. So this opening is our doorway to the gastric ganglia. So if medical management fails, then we are doing some intervention, minimally invasive intervention. So I'll be showing you a short video of the intervention, that how it is done. So while doing intervention, this foramen oval is the door or opening gate through which we can go to the to the gastric ganglia. Okay, so just now I've said that there are three branches of the trigeminal nerve. The first branch, which is also known as V1, commonly known as V1, supplies to the area of this yellow colored area of the face. Okay, it supplies to the nose, upper part of the nose. It also supplies to the bridge of the nose. It supplies to the forehead and up to the vertex. So everything which is colored yellow is supplied by the V1 branch or ophthalmic branch of the trigeminal nerve, which also includes the upper eyelid. Okay, next branch is maxillary division, which is commonly known as V2 branch. So V2 branch basically supplies to the tip of the nose. It also supplies to the ala of the nose, and it supplies to the anterior aspect of the cheek and anterior aspect of the temple. So the red colored area of the face is supplied by the maxillary division of the trigeminal nerve, and it also supplies to the mucous membrane covering the nose, maxillary sinus, as well as the upper part of the jaw and the gingiva. Okay, the third division is a mixed division. It has a sensory supply as well as motor supply, and everything which is colored in this pink color is supplied by the mandibular division. So it supplies to the lower part of the lip. It supplies to the whole of the mandibular area of the face. It also supplies the posterior aspect of the cheek and the posterior aspect of the temporal part of the face. So these three branches, they have a specific area where they supply, and depending upon the pain over the various area supplied by the trigeminal nerve, we basically classify it as a V1 or V2 or V3 trigeminal neuralgia. So if you see the individual nerve involvement, the most common individual nerve which is branch which is affected in trigeminal neuralgia is V2 branch. So the area which is colored in yellow red is a V2 branch, that is a maxillary branch of the trigeminal nerve. So this is the most common area, most common branch if you are talking about individual branch of trigeminal nerve. And the second most commonly involved branch is V3 branch. So V1, V2 is about 17%, and involvement of third branch, that is V3, is about 15%, and involvement of V1 as an individual branch is 4%. But the trigeminal neuralgia most common presentation is the combination of V2 and V3. So this V2 and V3 comprises about 32% of patient having trigeminal neuralgia. Okay, the second most common is the combination of all three, that is involvement of V1, V2, and V3, all three, which is about 17%, and involvement of V1 and V2 branch is about 14%. So if you see this slide, the more, if you are talking about individual branch which is affected, V2 is the most common branch. And if you are talking about the combination of branches which commonly gives trigeminal neuralgia, it is combination of V2 and V3, 32%. So most people, we will usually have the pain over the red colored area of the face, or the red as well as the pink color area, uh, uh, are the most commonly involved branches in case of trigeminal neuralgia. If you see the epidemiology of the trigeminal neuralgia, as I've already mentioned, this is the most common cause of facial pain in elderly population. So the onset of trigeminal neuralgia is usually after the age of 40, and the peak age of incidence is between 50 to 70. So you can clearly say that it is the most common cause of facial pain in elderly. And if you see the incidence, it is about every year about 4 to 5 patient in every 100,000 patient is diagnosed with trigeminal neuralgia, and it has a slightly more affinity, or it is more common in female than in male. So the difference is not that much, but if you see the ratio in male and female, uh, about 1.5 is to 1 is the ratio regarding the incidence of trigeminal neuralgia depending upon the sex. So as you can see, this lady is having a severe trigeminal neuralgia involving a V3 and most probably V2 branch as well. Okay, so if you see the causes, what are the causes that cause trigeminal neuralgia? So still now, the exact cause of trigeminal neuralgia is not known. So it is also, yeah, idiopathic, means like we don't know the cause of which usually causes the trigeminal neuralgia. And with the because nowadays we are so much dependent upon science and technology, and there has been so much advancement regarding radiological diagnosis, and gradually nowadays secondary causes of trigeminal neuralgia is commonly seen in many people, because we are going for MRI of brain. So any patient having facial pain or but atypical type of headache, and if it is not cured by simple medicine, we are going for radiological investigation. And various radiological investigations, especially the MRI, has shown that compression of the trigeminal nerve, especially at root entry zone, is the most common cause of secondary cause of trigeminal neuralgia. And if you see the what are the things that causes compression of the trigeminal nerve in this root entry zone, now 70% cases are vascular compression. So normally the superior cerebral artery, or anterior inferior cerebral artery, or even vertebral artery or basilar artery are are the culprit. And these vessels are the most common causes which causes compression of the trigeminal neuralgia, trigeminal nerve, and causes the trigeminal neuralgia. And other things that causes compression and causes the trigeminal neuralgia are various tumor of the brain. So if you see the compressive cause, there are mainly two cause. One is vascular, which is very common, 70% cases. Another is tumor, various tumor in the brain that can also cause compression of the trigeminal nerve and cause trigeminal neuralgia. So other causes, secondary causes of trigeminal neuralgia is post-herpetic neuralgia. Suppose if the patient has herpetic infection in either of the branches, V1, V2, V3, it can also cause post-herpetic trigeminal neuralgia. Multiple sclerosis, a neurological disease, can also cause trigeminal neuralgia. And sometimes facial trauma, like especially road traffic accident causing trauma to the face, and injury to either of the branches of trigeminal neuralgia can cause severe trigeminal neuralgia. Okay, so if you see the various type, What are the types of trigeminal neuralgia? So the first and the most common is idiopathic trigeminal neuralgia, where the cause of trigeminal neuralgia is unknown. Second is classic trigeminal neuralgia. In classic trigeminal neuralgia is mainly due to the vascular compression, especially the superior cerebral artery and anterior inferior cerebral arteries. So these are the most common culprits that can cause vascular compression and cause trigeminal neuralgia. And if the root cause of trigeminal neuralgia is vascular compression, then it is called classic trigeminal neuralgia. And apart from this vascular compression causing trigeminal neuralgia, all the other secondary causes of trigeminal neuralgia is known as secondary trigeminal neuralgia. So we can classify it in three different types. One is idiopathic, where cause is unknown. Second is classic, where the trigeminal neuralgia is due to the compression of the vessels in the brain or around the brainstem. And third is secondary trigeminal neuralgia. So apart from vascular compression, any tumor causing compression and trigeminal neuralgia, or multiple sclerosis, or post-traumatic or post-herpetic, is known as secondary trigeminal neuralgia. Okay. So if you see the clinical presentation of this patient usually complains of facial pain in one or more branches of trigeminal nerve. So usually patient in 95% of cases they have a unilateral facial pain, and this facial pain is usually the attack of facial pain is usually few seconds, about 30 seconds to about 2 minutes. So there is a short bouts of severe unilateral facial pain, and this pain is usually sharp, shooting, lancetting, or electric shock like pain which is experienced by the patient. And as you can see in this picture, the patient is having pain in the facial pain, severe facial pain, while brushing his teeth also. So normal day-to-day activity like brushing your teeth, or eating or chewing your food, or washing your face, or putting a makeup, so these normal activities can also trigger severe facial pain and cause trigeminal neuralgia, and cause decrease in quality of life of the patient. Thus the pain can be so much severe that patient might think of committing suicide. Okay. And thus it was also known as suicidal disease. So if you see the initial presentation of the patient, normally there will be a period of attack followed by a period of remission. That means there will be a attack of facial pain, and then there will be a long period of remission where the patient will be pain free in the initial phase of the disease. But as the disease progresses, gradually period of attack or periods of exacerbation will be longer and longer and longer, and periods of remission will be shorter and shorter and shorter. And finally, in the late stages of the disease, patient you will have continuous pain, and a small trigger like touching your face or brushing, these can cause trigeminal neuralgia continuously. So initially the patient will have intermittent pain followed by a long period of pain free period. This might be a month or week or even years, but gradually the painful episode will be more frequent, and pain free period will be shorter and shorter. Okay, so this is basically progression of the disease, and we usually get patient in the later stage of the disease, because in the earlier stages of disease patient will not be knowing what is causing the pain, so they will be going to the dental doctors thinking that dental problem is the cause of trigeminal neuralgia. So I'm sure those who are seeing trigeminal neuralgia have seen that many patients will come to clinic with removal of tooth. So in one attack they will go to the dental doctor, they will remove one teeth, and they will have a long period of remission. So in second attack also they will go to the dental doctor, and they think that okay, this teeth might be causing problems, so they will remove that teeth also. So if you see the patient with trigeminal neuralgia, they will have multiple teeth removed, because thinking that dental caries or dental cause was the cause that is causing facial pain. Okay. So in physical examination of the patient, usually you will appreciate allodynia and hyperalgesia. Okay, so allodynia basically means any yes, non-painful stimulation can be very painful in allodynia. In hyperalgesia, a touch sensation might be feeling as a pain in that patient. So allodynia and hyperalgesia is common finding in patient with trigeminal neuralgia. Okay, depending upon which branch it is involved. And normally in idiopathic trigeminal neuralgia, there will be no neurological finding in the patient. So the neurological examination will be normal in the patient with trigeminal neuralgia, especially the idiopathic and the classic trigeminal neuralgia. But in secondary trigeminal neuralgia, for example, if the trigeminal neuralgia is due to the tumor which is compressing the trigeminal nerve, or if the trigeminal neuralgia is due to the multiple sclerosis, then neurological features might be present depending upon what is the tumor. Okay, so depending upon the site of tumor in the brain, neurological finding may be present. And in multiple sclerosis, you may know patient will have difficulty in walking, patient will have difficulty in coordination. So these neurological findings are only present in case of secondary trigeminal neuralgia, and are absent in case of idiopathic and classic trigeminal neuralgia. Okay, so what are the investigation that you might go if if you think the patient is having trigeminal neuralgia? In previous days, in older days, um, only if the patient had a neurological feature, then we used to send patient for a brain MRI. But nowadays we are sending all the patient who are having trigeminal neuralgia to go for at least MRI of brain, because and it is known as trigeminal neuralgia protocol. Okay, this change in protocol is mainly because the the treatment basically is different. If we find out the cause of the trigeminal neuralgia in early phase. But for example, the example would be if a young patient comes with trigeminal neuralgia, which is very uncommon, but if the young patient comes with trigeminal neuralgia, our main treatment approach will be, and if the MRI shows vascular compression, then the main treatment approach will be microvascular decompression will be the main treatment. But if elderly patient comes with trigeminal neuralgia, and even if there is vascular compression, normally we go for radiofrequency ablation of the gastrin ganglia. So because of change of modalities of the treatment, MRI, we are doing MRI in most of the cases with trigeminal neuralgia, because of the reason that I've just mentioned. Okay, so if you see the pathophysiology of the disease, basically the exact pathophysiology of the disease is poorly understood, and that's why it is majority of trigeminal neuralgia are idiopathic in nature. But but nowadays compressive pathology causing trigeminal neuralgia is slowly the incidence or is growing more and more. So in case of compressive pathology that is causing trigeminal neuralgia, what happens is that the local pressure by the vessel or by the tumor over the trigeminal nerve will cause demyelination of the trigeminal nerve. Okay, the myelin sheet which is covering the trigeminal nerve will be gradually it will be destroyed, and once the myelin sheet or the covering of the trigeminal nerve gets destroyed, then there will be ectopic generation of the signal from the damaged nerve, and which is the main cause of giving the electric shock like pain or sharp shooting lancetting type of facial pain in the patient. So the local pressure either by tumor or vascular vessel, which will basically will damage the outer layer of the trigeminal nerve, causing demyelination of trigeminal nerve, which will lead to abnormal depolarization at that area and cause ectopic discharges. So this is one of the cause of peripheral sensitization. So other peripheral sensitization will also come in trigeminal neuralgia. Especially there will be upregulation of the nociceptors. There will be increased sensitization of the afferent fibers, which is carrying pain. Okay, so these are the peripheral sensitization. And in central sensitization, which is the main cause for allodynia and hyperalgesia, is due to the basically uh, in the if you see the spinal cord, in the central part there is a gray matter. So in the gray matter there are lots of lamina placed. So there are various laminas are there in the gray matter. So the inner lamina are basically responsible for touch and pressure, and the outer lamina are basically responsible for carrying pain sensation. And what happens in trigeminal neuralgia, especially if the patient is centrally sensitized, the inner layer of the inner lamina of the gray matter will sprout out and gets connected with the outer lamina. Oh, so that is the main cause of having allodynia or hyperalgesia. Even the touch sensation will be interpreted as a pain, severely painful condition in these group of population. Okay, so that is the main pathology of the disease. So if you see the differential diagnosis of the facial pain or trigeminal neuralgia, multiple sclerosis is one of the differential diagnosis. And in multiple sclerosis, there will be bilateral trigeminal neuralgia. So only in multiple sclerosis, there will be bilateral trigeminal neuralgia. In normally, the trigeminal neuralgia is unilateral in nature. So various myofascial pain or pain in the myofascial pain of the masseter muscle or the temporalis muscle can also mimic trigeminal neuralgia. So various this ENT causes can also mimic trigeminal neuralgia, or temporomandibular joint arthrosis can also mimic trigeminal neuralgia. So dental disorder are common differential diagnosis in trigeminal neuralgia. That's why many people with trigeminal neuralgia usually gets their teeth extracted, thinking that the teeth is the main cause that is causing facial pain. Okay, so vascular migraine and other type of migraine are also common cause of trigeminal neuralgia. Giant cell arthritis, glossopharyngeal neuralgia are also differential diagnosis, and in many times this trigeminal neuralgia will be associated with glossopharyngeal neuralgia. Okay, so the two diseases can coexist in a same person. So trigeminal neuralgia and glossopharyngeal neuralgia can coexist in a same person. A post-herpetic neuralgia are also differential diagnosis, and other non-specific facial pain or atypical facial pain are also common differential diagnosis of trigeminal neuralgia. So if you diagnose any patient with trigeminal neuralgia, the the main treatment is always conservative. Okay, we don't go for intervention management unless required in those patients having trigeminal neuralgia. So first line of treatment in trigeminal neuralgia is always oral pharmacotherapy, and I'm sure Dr. Mahmood will be explaining more about this, but I'm just giving you an outline of the drugs which are commonly used for trigeminal neuralgia. So the old drug which was manufactured in 1960 is still number one for the treatment of trigeminal neuralgia, that is carbamazepine. So normally if you start carbamazepine, we usually start with a very low dose. For example, 100 milligram a day or 200 milligram a day we are usually starting, and gradually we are escalating the dose of carbamazepine, and normally people will be stable between 400 to 800 milligram per day of carbamazepine can give a in good pain relief in about 80 to 90% of patient. Okay, but as you know, carbamazepine is a very old drug, so there are various side effects associated with carbamazepine. And so common side effect would be like skin rashes, sun sensitivity, Steven Johnson syndrome, which is a life which might be life threatening, or hyponatremia is also one of the most common side effect or adverse effect of carbamazepine. It can cause bone marrow depression and cause aplastic anemia. Visual disturbance has been noted with carbamazepine. Weight gain, nausea, vomiting are also common adverse effect of carbamazepine. Okay, so if you encounter any adverse effect of carbamazepine, especially hyponatremia or skin rashes, then you might have to go for other drugs for the treatment of trigeminal neuralgia. The second line of drug for the treatment of of the trigeminal neuralgia is gabapentin, anticonvulsant drug. Normally the maintenance dose will be about 900 to 2400 milligram. I would like to. I forgot one thing to tell you. The carbamazepine usually normally the patient will be stable between 400 to 800, but maximum dose of carbamazepine that we can use is about 1200 milligram. Okay, so until the patient reaches 200 milligram, and if the patient is having no side effect of the drug, we can safely use carbamazepine up to 1200 milligram. But if the patient requires more carbamazepine, then you might think of going other alternative modalities of treatment. For example, adding other group of drug that I've mentioned in this PowerPoint, or go for intervention treatment. So if you see, the second line of treatment, gabapentin, lamotrigine, and baclofen are very commonly used, especially if you encounter hyponatremia after carbamazepine, then we are using gabapentin or baclofen or lamotrigine. Or and so in as a third line of drug, phenytoin, valproate, as well as amitriptyline are also commonly used in combination with carbamazepine for the treatment of trigeminal neuralgia. Okay, so if this conservative management fails, or if there is an adverse effect associated with these drugs, which was giving good result, but now if the oral pharmacotherapy is not working, then only we go for the intervention treatment. Nowadays, it is said that oxcarbazepine is also a new drug, which they say has an equal potency as carbamazepine. But in my clinical practice, I found out that carbamazepine is the best. If carbamazepine doesn't work, it is very difficult to treat the patient with oral pharmacotherapy, and and then you might want to think of going to other intervention modalities. Okay, so if you see the intervention treatment which is currently used nowadays for treatment of trigeminal neuralgia is the list that I've all mentioned. In this list, the upper five, then that means number one to number five is commonly used nowadays. We are going for these upper five treatment, but the last one is basically the experimental treatment which is going on, because they have found out some problem with in this treatment. Especially they were planning for neuromodulation or stimulation of the gastric ganglia, but they are finding it difficult to anchor the neuromodulation lead in the gastric ganglia. So it is still in the experimental phase. But the first one, surgical microvascular decompression, is commonly done, and especially it is done in a young patient with vascular compression or classic trigeminal neuralgia. In young patient, we are going for surgical microvascular decompression. We usually send the patient to neurosurgeon for a surgical microvascular decompression. So gamma knife radiation therapy, I think Dr. Sabha will be doing this gamma knife radiation therapy. Not only this, he is also trained to do this percutaneous radiofrequency of gastric ganglia. Okay, so but gamma knife radiation therapy is usually done by radio oncologist, where a specific in a specific area, very high dose of radiation is given, mainly in the gastric ganglia, to destroy the gastric ganglia and to get relief of pain. But we pain physician are usually doing either percutaneous balloon microvascular decompression, or percutaneous glycerol nerve destruction, or we are also using percutaneous radiofrequency of gastric ganglia. If you ask my opinion, I would usually go for percutaneous radiofrequency ablation for gastric ganglia, because it is a very easy procedure, very short procedure. Within about 20 to 25 minutes, whole procedure gets over. And when I was young, when I was practicing pain in the first time, and when I was learning this percutaneous radio frequency of gastric ganglia, I thought I would never do this procedure because it was very dangerous, putting needle into the foramen ovale and going up to the brain stem to give the heat lesion. I was actually I had a very negative thought of doing this procedure. I thought that I would not do this procedure when I go back home. But, uh, but, luckily or unluckily, this is the procedure that I'm doing most in my place. So in my place, I've done almost 110 cases of trigeminal neuralgia within a 5 years period. So which is quite, it is the which is quite the amount is quite big. Okay, because I'm basically motivated to do this radio frequency ablation of gastric ganglia because the relief is immediate. After the procedure, patient has a pain relief immediately after the procedure, and you can see a smile in patient face because patient is having was having severe sharp pain, and it was basically impairing or decreasing the quality of life. And once the pain is relief, the smile the patient gives you after the procedure is very precious. So that is a motivating factor for me for going for radio frequency ablation of gastric ganglia. Okay, so surgical microvascular decompression is the first choice, as I've already mentioned, in young patient with vascular compression, that is in classical trigeminal neuralgia. So one of the main advantages of this surgical microvascular decompression is pain relief is almost permanent or a long for a long period of time, because what we are doing in this surgical microvascular decompression is we are basically going from the retromastoid approach. You can see here from just behind the ear we are going into the brain, mid brain, and then we are identifying the vascular compression. So this is the superior cerebral artery compressing the trigeminal nerve at root entry zone. Okay, so if this is the cause, then simply putting a Teflon pad or a cushion between the vessel which is compressing the trigeminal nerve can give a good pain relief. And this can be for a long time, or it can be a permanent treatment in some cases. But we usually do this, or we encourage this procedure in a young patient because there is some increase, there is some mortality as well as morbidity associated with this surgery, because after all it is a surgery in the brain where surgeon is going behind the ear, cutting a part of your skull, going into the brainstem. So it can be, sometimes there can be mortality and morbidity. That's why it is not the first choice of intervention or first choice of treatment in elderly population, because in elderly population they might have various comorbidity, for example diabetes, hypertension, and usually these group of people, elderly group of people, would not want to go for surgery, and they would want alternative method apart from surgery, which we provide. And Dr. Sabah and we, basically a pain physician, Dr. Mahmood, Khalid, Dr. Saf, we all give these other modalities, a minimally invasive percutaneous procedure which can have a very beautiful result with very less mortality and morbidity. Okay, so these are the procedure that we commonly do. So we are basically inserting a needle, minimally invasive. This is a very minimally invasive procedure where a small needle is introduced just lateral to the angle of mouth, and you can see this needle is going up to the gastric ganglia, and depending upon which nerve, we basically ablate the nerve. And there is also before ablation of the nerve, we have to find out, we have to specifically identify which nerve is causing problem, and which can be done by sensory and motor stimulation of radio frequency, which I'll be demonstrating you in a short video. Okay, so we are doing either heat ablation of the radio, this gastric ganglia, and causing and giving pain relief, or we can also go for this injection of glycerol in the gastric ganglia, or we can also inflate a balloon over a gasoline ganglia in the Michel's cave and cause mechanical destruction of the gasoline ganglia and take care of pain associated with trigeminal neuralgia. Okay, so these are the fluoroscopic or the X-ray images of the three different procedure. Here you can see a needle is going through the foramen ovale in the petrous part of the temporal bone. See, this is the triangular in structure, and in the apex is the location of the gasoline ganglia. So we are putting a needle and we are basically burning this nerve. Okay, so this is the opening. As you can see, a small opening is there between the mandible and maxilla. So this is the opening through which we go inside the gastric ganglia. And this black color dot is a needle. And this is also the needle going into the Michel's cave. In the picture, right upper side of the picture, you can see a big needle going into the gastric in the foramen ovale, and we are inflating a balloon and cause mechanical destruction of the gasoline ganglia by the compression. And third is here you can see the needle is inserted into the Michel's cave and glycerol is being injected to take care of pain associated with trigeminal neuralgia. So another method which is growing its popularity nowadays is gamma knife radiotherapy. So this gamma knife radiotherapy is growing its popularity because it is the only procedure which is non-invasive. Okay, so the procedure that I had just mentioned previously is a minimally invasive procedure, but this gamma knife radiotherapy is a completely non-invasive therapy where patient is placed in the MRI. This is the MRI machine. Okay, and patient is placed under the MRI, and a very specific in a very small area, high highly concentrated radiation is emitted which with the help of MRI, that is at the gasoline ganglia, and they are destroying the gasoline ganglia. And this procedure can sometimes be painful, thus it is always done under the sedation. So we sedate the patient, put the patient in this MRI machine, which is compatible, which can provide this highly concentrated this radiation in a specific area of the body to destroy the nerve. So in United States, as well as in developed country Europe, this gamma knife radiotherapy is slowly growing its popularity for the treatment of trigeminal neuralgia. So if you encounter any patient with trigeminal neuralgia, this is the protocol that we commonly follow in my clinic. Okay, so once the patient is diagnosed as trigeminal neuralgia, we go for medical management, and only if the medical management fails, then we go for the intervention management. Okay, and in intervention management, if the patient is young, we go for microvascular decompression if there is evidence of vascular compression, and in case of elderly, we usually give advice to go for the radio frequency ablation of the gasoline ganglia. So this is the protocol that we usually follow. Always go for a medical management first. If it fails only, then go for other modalities of treatment. Okay, so there are a few complications associated with the treatment, though the complications are very low. So these complications, there is a very low or very less mortality and morbidity associated with radio frequency ablation of the gasoline ganglia. But having said that, there are few complications, such as there can be paralysis of masseter muscle. Okay, this paralysis of masseter muscle is usually a short is for short period of time. Gradually patient will recover. Okay, so gradually within 3 to 6 months, slowly the weakness, if there is a weakness, it will be recovered. There can be temporary paralysis of third and fourth cranial nerve. There can be rupture of or puncture of the carotid artery if it is done by non-experienced person. So corneal hypoesthesia, corneal reflex loss is most common with radio frequency ablation, and it is least common with balloon compression. And anesthesia dolorosa, okay, this is one of the very dreadful complication of we pain physician, because in anesthesia dolorosa a different kind of pain will come to the patient, which is very difficult to treat with the oral pharmacotherapy. So single oral pharmacotherapy. So in anesthesia dolorosa, basically when we ablate the nerve, usually nerve will regenerate and basically and grow in a normal fashion. But in anesthesia dolorosa, what happens is there is cross talk of the nerve. Okay, and because of the cross talk of the nerve, there will be different kind of pain in the patient, and it is very difficult to treat with the normal conventional oral pharmacotherapy. And since we are putting needle into the near to the brainstem, infection and meningitis are also common cause. So these are the common complications that you should be aware while going for the radiofrequency ablation of in the patient. Okay. So I have prepared a short video. It is about 2 to 3 minutes, about 5 minutes video, in which I have shown you how. What are the things that we do while doing radio frequency ablation in a patient with trigeminal neuralgia? Let's go to this through this video once. Okay. So as you can see, there will be a severe, sharp facial pain, especially in female, and it is unilateral. So once we diagnose, and if medical management fail, we are putting the needle into the gastrin ganglia and ablating the nerve. Okay. So, and since this is an invasive procedure, you can see it is always done in operation theater with all the monitor, and preferably one anesthesiologist should be by your side, because you are putting the needle near to the brainstem, and sometimes there can be respiratory failure or injury to the brainstem. Okay, so one thing I forgot to mention here, so all the emergency drug and resuscitation equipment should be there, and IV access should be there, and prophylactic antibiotics should be given. And as you can see, this is the opening, and this is the needle which goes near to the air. I want to stop. Okay, so this needle, you should be very careful, because if our needle goes beyond this, it can damage the brain or brainstem. So our end point is at the junction between the clevis and petrous part of the temporal bone. See, this black triangular structure is a petrous part of the temporal bone. So our needle is going through the foramen oval, but we should stop as soon as we get this junction between the cleavers. So if you see, this is the brain. Okay, here there is a location of pituitary fossa. So behind the pituitary fossa, you can see cleavers, a bony projection which is known as cleavus, which descends downward, and at the junction between the cleavus and petrous part of the temporal bone, we should stop our needle, because if we go beyond this, we are basically damaging the either the temporal lobe or the brainstem. So this is the border, or this is where we have to stop our needle in the lateral view of the fluoroscope. Okay. So in this, we first take up in an AP picture. This is the anterior posterior picture of the skull. Then after taking a AP view, we basically, what we do is we tilt the fluoroscope more to the caudal side, and this is called submental view, because we are viewing our we are seeing the face from below. So below the mentum or below the chin. So this view is known as submental view. Okay, after the submental view, we rotate the C-arm. After this view, we rotate the C-arm in the ipsilateral side where there is pain. Okay, so here I will stop. So after getting a submental view, we rotate the C-arm to the ipsilateral side where there is pain, and when we rotate the C-arm about 15 to 20 degree in the same side where the pain is, we can see a opening, a oval opening below the mandible, between the mandible and maxilla. So this oval opening is known as foramen ovale, and through this opening we are passing our needle okay, and growing near to the brainstem for ablation of the trigeminal nerve. So this is a procedure which is done by me, and I'm showing it to you. Okay, so here you can see a small opening, and this is the needle which has gone to the gastric ganglia. And always remember, in this view we have to square the mandible in the lateral view. That means you can see two mandible here. In the lateral view, we have to bring this two mandible in a one place. Okay, this is called squaring of mandible. This needle placement can only be assessed when two mandible come in one, or this opening, white opening, is a external auditory meter, so this should be clearly seen, or these two mandibles should be aligned in such a manner so that only one mandible can be seen. That means it is called a true lateral view of the head. So in the final needle placement is always done in true lateral view. So you can also see here there is a clevis, and this is the petrous part of the temporal bone, and our needle is right at the junction. Okay. So our needle is right at the junction between the clevis and petrous part of the temporal bone. Okay, and this procedure is done under local anesthesia. We don't give general anesthesia while doing this procedure. So patient is completely awake. So once we put our needle there, we stimulate the nerve in 50 hertz current. This is very important because there are three branches, and we have to burn the branch which is causing problem. We should not ablate the other nerves. So to be specific and burn the nerve, or give the radio frequency current in that nerve, patient should be awake. And once we put the needle, we should stimulate and try to find out whether the nerve which is causing problem is our target or not. If our nerve, if the stimulation is in different branches, we have to manipulate the needle so as to get the main branch which is causing trigeminal neuralgia pain. Okay. So our stimulation is, we are getting stimulation at zero point 0.3. That means we are very close to the nerve. You can see we are gradually increasing our current, and at around zero point 0.3 volts she is having pain. So we are doing motor stimulation also. So this is the radio frequency machine, and you can see the needle is going through the angle of the mouth, and the tip is going up to the brainstem, near to the brainstem. And before burning, we give local anesthesia if CSF is not there, and we burn the nerve at 60 degree, 65 degree, and 70 degrees Celsius at 70 seconds. So here you can see the duration is 70 seconds, and the temperature is 60 degree, 65 degree, and 70 degree. So during the procedure, we should also always check corneal reflex. As I mentioned, in one of the complication is loss of corneal reflex. So we always have to check the corneal reflex when we are doing this procedure. And once we think that corneal reflex is getting diminished, we have to stop doing this procedure, because otherwise patient will have loss of corneal reflex and have exposure keratitis and other ocular problems. So here I am checking the corneal reflex between each procedure. So after the procedure, you can see it is very easy. Patient is awake, and I have already removed the needle. Okay. So this is the Okay, so this is the whole entire process, how we do the radio frequency ablation. So if there is any question, I'm ready to answer either now or later after the webinar is at the end of the stages. Okay. Okay, Dr.
Thank you, Dr.
Sabah,
Shirish. Yes, thank you, Dr. Shirish, for your nice presentation and
thank you very
interesting lecture full of experience. There is a lot of question, but seriously, we put it at the end. Okay.
okay.
Okay. So now I want to welcome Prof. Dr. Khalid Murad from Iraq. He is a chief of Iraqi and Arab Federation of Pain Management. He is MD anesthetist with master degree of orthopedic surgery. Also has a spinal endoscopy fellowship from Germany. Achieved FIPP and has a number of local and international publications with experience of this disease of trigeminal neuralgia for more than 200 cases. Welcome again, doctor. You can begin now just for sharing. Just a second.
Thank you very much, Dr. Sabah, for this presentation. Thank you, Mr. Shiris. I like your experience in this field. Okay, you can start sharing my lecture.
Yes, okay.
Really, Dr. Shiris covered whole of subject theoretically and practically. So I would like to concentrate on some practical point in my experience, in my cases, and we would like to discuss it later. So next slide. As he said, I will, some slide I will go quickly because it's mentioned by my colleague, Dr. Sherish. Neuralgia, it is a disaster, miserable, and it is originally from Greek neuroma. Next, it's mentioned, it is all disease related to human being. He make a very big suffering, and it's act on the life. Next, please. Next, please. Yes, and it is caused the pain, which is the main causes of visiting a doctor, and main causes for economical effect on the country, on the family, on the life, and enjoy the life. And it is as Dr. Sherish said, it is all disease since 1677, and so all the trial of management start since a long time. Next, please. So it is defined as a unilateral, severe, brief, stabbing, lancetating, recurring pain, and distribution in the distribution of one or more branches of the fifth cranial nerve. Trigeminal neuralgia also, yes. Next. Okay, no problem. Next. Etiology, also mentioned by the first lecture, it is idiopathic, demyelination, multiple sclerosis, vitreous-rich compression, post-traumatic, intracranial tumor, intracranial vascular abnormality as viral etiology. Next. I need support of Dr. Sabah because, as I said, my technological facilities here is difficult. So other disorders also cause trigeminal nerve include neuralgia, syphilis, tuberculosis, tumor, basilar meningitis, pontine disease, skull fracture, aneurysm, and psychoneurosis, also cavernous sinus thrombosis. Next. So the pathophysiology is related to focal demyelination. So why it is so that's why it is related to multiple sclerosis. Next. Next, please. So look, this degeneration, this is the cause of pathophysiology of the pain transmission. Next. And this is the trauma to this area, also one of the causes of trigeminal neuralgia. Next. Age, this is a schedule of the age, mostly in the old age, after 15. And there is some cases below 30, 40. And this is so most common disease of old age people. Next. And as they said, female to male. And I like this slide. Also, Mr. Shiris, you mentioned about it. always it is come on the stage, the complaining. But mostly the patients come in the first and middle stage, not at the last stage. And commonly in Iraq, I get referral from dentists because most of them go to the dentist and make a tooth extraction, and or go to the ENT people, and so after that they referral them to us. Next. And this is the complaining mostly as the incidence is 8 for 100,000 cases, so it is look more big, big percent. And female to male is affected side right more than the left, and the division of trigeminal nerve V2, V3, and V1. Yes, next. And this is the diagram of the distribution of the nerve effect. Next. And this is the trigeminal nerve neuropathy in transmission, trigeminal nerve branches. And the source of the pain, mostly I notice in my patient, is coming from the angle of the lip and nose. This is the center of the pain, most of the center, due to stimulation, due to washing, shaving, makeup. Next. Next, please. Yeah. Yes, this is trigger zone. Look, this trigger zone usually located on vermilion border of the lip, ala of the nose. This is the main trigger point, and cheek and chin and around the eye. Next. Highly sensitive area. High pain is always a patient mentioned that I get pain, shocking pain, electric-like pain from the angle of the lips. Type of trigeminal neuralgia. It's also mentioned typical, atypical, pre-trigeminal, multiple sclerosis, secondary, trigeminal neuropathy, traumatic, and failed trigeminal neuralgia. Next. Next. This is typical. This is atypical neuralgia, typical and atypical neuralgia. Atypical neuralgia, unilateral, prominent, constant and severe aching pain, burning pain, superimposed upon otherwise typical symptom. Some believe that atypical trigeminal is due to vascular compression upon specific part of the trigeminal nerve. The portio minor, yes, listen. While other theories, atypical trigeminal neuralgia has a more severe progression of atypical trigeminal neuralgia. Next. Next. Pre-trigeminal neuralgia. Please come back to the previous slide. Yes. It is a pre-trigeminal neuralgia, day to day before the first attack of trigeminal neuralgia pain. Some sufferers experience all sensation of the pain, such as toothache or discomfort, paresthesia. Multiple sclerosis related trigeminal neuralgia, symptom of multiple sclerosis, raised trigeminal neuralgia are identical to typical trigeminal neuralgia. Mostly is bilateral by multiple sclerosis. I get about 2 or 3 cases bilateral trigeminal neuralgia, and more commonly seen in people with multiple sclerosis because it involved the formation of demyelination plaque with the brain. Next. Next, please. Next. Dr. Sabah.
Yes, doctor, I make next also.
Yes. No. Come back. A clinical, it is all mentioned by my colleague. As we said, sudden, unilateral, intermittent, sharp, shooting, lancinating, shock-like, touching, superficial. Pain is usually confined to one part of pain is rarely crosses the midline. Attack do not occur during sleep. It is not occur during sleep. Pain is a short duration. not long. It is shock, electric-like shock, but may reoccur with the extreme cases. The patient will have a frozen mask-like face. Common trigger zone, as I said, include cutaneous corner of the cheek, area of the nose, lateral brow, intraorbital tongue. A trigger area on the face are so sensitive. Even air current, يعني like the fan air is also trigger the episode of the pain. 10 to 12% of cases is bilateral or occurring in both sides. Mainly seen in case with a systemic involvement include sclerosis or expanding cranial tumors. Next, diagnosis. As we said, now it is there is some facilities in Iraq to do a CT scan for all cases. So I think we'll make this regime that before that we depend 100% on a clinical diagnosis. But if there is a facilities, we can send the patient to CT scan and MRI diagnosis the nerve to know the other causes of the trigeminal neuralgia. Next, differential diagnosis: migraine, sinusitis, dental pain, tumor of the nasopharynx. Post-herpetic neuralgia is the main differential diagnosis of the trigeminal neuralgia. Next, a treatment. I will leave a space for other colleague, pharmacist, Dr. Mahmoud, to talk about medical treatment. But still till now, the drug of choice for trigeminal neuralgia is carbamazepine. It is our drug of choice till now. I don't know whether it's a new update about this topic. Mr. Mahmoud will tell us about this. Next, we also use duloxetine, also a nice drug for its combination with Tegretol is give a good result. Surgery, really, in my experience, I didn't see a patient did surgery for trigeminal neuralgia because there is a very limited people who can do this surgery. Also, our patients always refuse to make this invasive craniectomy and brain, and also it's scary, big mortality rate. Yes, I in my experience, I did radiofrequency ablation, C-arm guided, to young people, and they get a very good result. But still, the prognosis of the young people is less than the old people. But it gives a good result. I don't say that all the young people must referral to do surgery, vascular surgery. You can try and do a block, and you can get a good result. To me, I get about 80% of the people, young people, get a very good result from radiofrequency ablation, C-arm guided. So I don't encourage sending to make cranial surgery, because as I told you, it is limited people and the patient is always fair to make a craniectomy for this complaining. Next. Yes, this is microvascular decompression. This is surgery. This surgery by put a Teflon. Look at Teflon. Teflon between vein and between artery and nerve. Next. So still radiofrequency ablation is the best, to me, it is the best minimal invasive procedure to get a good result. And you can make a good success and development in field in treating trigeminal neuralgia, because you change the life of the patient from suffering to smile. Patient can enjoy his life. Otherwise, he was mask face and depressed, and the family depressed, and taking a lot amount of Tegretol with its side effect. So Trigeminal neuralgia is a very basic technique in pain management, and I encourage all people, pain specialists, whether junior or specialists, to develop their experience in making radiofrequency ablation for trigeminal neuralgia. It is minimal invasive, cheap, and time consuming, and effective with a good result. But to me, there is it's carry a recurrence risk. I don't know about experience of Mr. Shirish, but some people, about 30 people, 40% of people come again with recurrence after 4 years. But even the recurrence, the relapse was not so severe. He can use a little amount of the drug, Tigritol, less dose, and make a good improvement. Next. And this is surgery, I think, Teflon under the bezel. Next. No, you go come back. Go ahead. You go come back. Yes, go ahead. Next. Yes, about radio surgery. Yes, in Iraq, we started to use gamma knife surgery. Maybe Dr. Sabah has a good experience, better than us in this subject. But mostly, really, I get 2 cases after radio surgery, after the gamma knife. They have the same complaining. I don't know. It's failed surgery. And also the gamma knife, it is not short. It is also long surgery. And cost in Iraq cost about $1,000 for cases. And the patients also complain from the helmet and something put on the head. Also, the successful rate, it is not more than 70%. It is mentioned in textbook also, and it's the recurrence rate also is very high, about 6 months after the radio surgery. The recurrence is high. The successful rate is less. It is, yes, non-invasive, but it is cost effective. And I think I don't know, Dr. Sabah, she can tell us about the gamma knife. In Iraq now, 2 or 3 center uses this technique. One center in Baghdad, I think, a neuroscience hospital, and one center in Basra. But I get, as I told you, 2 cases make a gamma knife, and they didn't get a very good result. I don't know, because of technique or because of the effectiveness. Next. In trigeminal neuralgia indication, this is indication. Radiofrequency ablation, it is not for pain, for headache, not just for radiofrequency for the trigeminal neuralgia. We can use for cluster headache, intractable ocular pain, cancer pain, and contraindication, local infection, sepsis, coagulopathy, and increased intracranial pressure, major psychopathological. I'm sorry I have a video, but because the technical problem, and I am outside of my home, so it is difficult to show it. Complication also mentioned in the first lecture, loss of corneal reflex. So yes. So always you monitor the corneal reflex during operation. Motor deficit improve with years, sometime, or months. I have a case like motor weakness of the mandible, because as we told you that the mandibular branch is 20% of it is motor and 80% is sensory. Carotid artery puncture, it is just in a blind technique. Some people before that time, they use blind technique to reach the trigeminal ganglia block. It is difficult and it is crazy surgery. Retrobulbar hematoma in cheek. It is mentioned also. Infection is rare. Infection always. Why there is infection? Infection if your needle pass in the oral cavity with saliva and something. So always when you start at the case in early cases, learning curve, you put your finger in the cheek to see whether the needle is passed through or not. And also you can cover by antibiotic pre and post operatively. And also if you get CSF drop, you put a chance that is the patient may get infection, so you can cover with antibiotic. This cause of infection. Next, efficacy. Radiofrequency lesion, as I told you, it is about 91 to 93 successful rate. It's high successful rate, but there is a relapse rate. Always, you told your patient that maybe a relapse of the symptom after a few years, not months, but a few years, mostly above 4 years. Next. My experience, it is some for patient up to, this is old experience, up to 2018. I do more than 100 cases. I get about 80% very good improvement above, yeah, better than using a drug. Some patient remission, 4 patient remission, about, I don't know, it is not clear. 8 patients need a recession because remission after the surgery. 4 patients not improved, especially in early learning curve. That's my message in early. Yes, as Dr. Sheris said, he first you scared of the operation. How do you put in needle and go to the foramen ovale and go to the petrous part of temporal bone and go outside below the near the brain and make radio frequency ablation. Especially you can, yes, in the first learning curve you go in foramen ovale, but you afraid to go to cross the petrous part of temporal bone. You scared. So the learning curve and first learning curve, I didn't 4 or 5 patients not improved. Mild weakness, 40% mild weakness, but improved with 3 months, 3 to 6 months. One patient aid always, as in the first lecture, always you put anesthetist, you put resuscitation drug, you prepare everything, IV cannula, in the operation theater, qualified operation theater, because I get patient develop cardiac arrest, old, emaciated, and many disease. I maybe because of pain, neurogenic pain, or because also some if you put xylocaine, always sure when you inject xylocaine, you must there is no CSF. Otherwise, xylocaine go to the brain and total spinal and hypotension and shock and every, it is very bad complication. So this is about my, now we are doing it routinely, this surgery, this minimal invasive technique, and very good result. And I think I advise to the a new technique, some people now, it is highly percent of people now using ultrasound. It's also a nice machine. I have no full experience about it. I get some referral kits from sonarist people. If there is no improved sonar, so refer to C-arm guided, because in C-arm guided you can enter the foramen and go to the ganglia. So it may be we change the diagram that put by Dr. Sherish. His diagram first, if young, go to the surgery, and after that go to the radio frequency. After that, medical or radio frequency. So we must put a place for ultrasound guided, maybe before the radio frequency ablation, because it's most safest drug, safest technique for the radio frequency ablation. Thank you very much. Thanks for your kind time. And thanks for Dr. Sabah and Dr. Sherish and the company and Dr. Mahmoud for this time. Good luck.
Thank you, Dr. Khalid, for your interesting presentation and valuable information. Now I share my presentation. Is my topic visible?
Yes, yes, Sabah.
Yes.
Sabah.
So it's my turn. I am a moderator and a speaker of this webinar. I would like to introduce myself. I have MD board certified in radiology, pain management specialist with MSK ultrasound fellowship from India, trainer in radiology department, especially MSK ultrasound and Doppler ultrasound. I'm interested in interventional spine and tumor procedures. Now my topics is about ultrasound guided trigeminal nerve block. As Dr. Shirish and Dr. Khalid explained the fluoroscopy, now we begin with ultrasound guided. As you know, trigeminal neuralgia is a chronic condition with severe, intense pain, episodic with recurrent repetitive attack, electrical shock-like, typically occurring in one side that disrupt daily activities. Now we begin with anatomy of the trigeminal ganglia. As you know, trigeminal nerve arising from trigeminal ganglia, which lies in the petrous portion of the temporal bone. Then it divides into three branches, as Dr. Shirish and all explained that, V1, V2, and V3. V1 is the ophthalmic division, V2 is the maxillary division, and V3 is the mandibular division. Now I begin with the nerve of the face. Why I begin with a nerve of the face? It is the terminal branch of a trigeminal nerve. Some question ask, can do radiofrequency for this terminal branch? I say it is not, because it causes severe pain and severe numbness in the face if we do radiofrequency. So the solve here is by doing a cryoneurolysis of this terminal branch of a trigeminal nerve. It is very safe and effective. For this terminal branch. If the distribution of pain or neuralgia occur in this supraorbital, infraorbital, or mental division. So as in this picture appear, if my mouse click, okay. So in this picture, you see that the ophthalmic division is continuous as a frontal nerve. Then the frontal nerve is divided into medial and lateral branch. The medial branch is the supratrochlear nerve, and the lateral branch is the supraorbital nerve. This supraorbital nerve leaves the orbital roof through the supraorbital foramen, which is just at the eyebrow, if you see, just at the orbital roof. Which innervation it gives? It gives sensation to the superior aspect of the eye and forehead, cutaneous covering over the large portion of the scalp, as explained by this picture. When need to do this supraorbital nerve block? Either idiopathic supraorbital neuralgia, or sometimes there will be entrapment. You know, some swimmers will wear glasses during swimming. These glasses make entrapped over the nerve, and maybe also secondary to herpes zoster infection. How to do ultrasound technique of this supraorbital nerve to do cryoneurolysis? We have two probe ultrasound probe, curvilinear and linear. The curvilinear is, as you know, it is a low frequency probe. So there is inverse relationship between the wavelength and the frequency. So it just see the deep structure. By this way, we just examine the superficial structure, which is the supraorbital foramen. So now we use the linear probe with high frequency. So its wavelength, it's low. We use this probe. We begin from the forehead and till downward, till reaching the eyebrow. See, there will be a defect in the cortical frontal bone, supraorbital ridge. You see, this the bone is hyperechoic, as hyperechoic line or white line. Continue scanning until reach downward this defect, then open the color Doppler. You see the vessel to avoid vascular injury. Now, how to do this nerve block? We have two plane, either in a plane technique or out of a plane technique. So always we use in the pain management in a plane technique for the safety. The in a plane technique, we put the needle just at the same side of the ultrasound probe with acute angle of approximately 30 degrees. Why? In order to see the whole length of the needle, because it is safer to reach the nerve and avoid this vascular injury. If we enter by more obtuse angle, more than 45 degrees or more than that, or even out of a plane technique, we see just the tip of the needle. So this causes a problem and it is unsafe. We use needle, which type of needle? We use 25 gauge needle, approximately 1 inch in length, then put local anesthetic. Firstly, as disinfection, it is important. Then put local anesthetic. After that, do a block by cryoneurolysis. Now we begin with the infraorbital nerve. Infraorbital nerve is also as supraorbital nerve. It is a purely sensory nerve. It is a branch of maxillary division of a trigeminal nerve and live through the infraorbital foramen. Here is the infraorbital foramen, about 2.5 cm from the midline. Then it is divided into superior alveolar branch and gives sensory innervation, as by this picture appear, to the upper incisor, canine, gingiva, lower eyelid, lateral nares, and upper lip. Now we go to ultrasound technique. Also, we use the linear high frequency probe, but now the probe position we put by sagittal. We put the probe sagittal view. Sorry. It is put sagittal just at the infraorbital ridge and the maxilla. You see there is a defect there. Why we put sagittal? We can also use transverse position. It is not a problem. But by this way, it is easy to put the needle either from below or from above by any plane technique. Also open the color Doppler to avoid vascular injury. You see by this picture, it is just beside this vessel. How to do needle insertion? We said it is very safe by any plane technique, by putting the needle beside the probe with acute angle about 30 degrees to 45 degrees. Now we go to the mental nerve, which is also a purely sensitive nerve, a branch of mandibular division of a trigeminal nerve. It leaves the mandible through the mental foramen. Here is the mental foramen, also about 2.5 cm from the midline. Usually this nerve is vulnerable to trauma and entrapment, and it innervates the lower lip, as by this picture appear, lower lip, chin, corresponding oral mucosa. When to do block of mental neuralgia? Some players of kickboxing, they use like band here and make entrapped over this nerve called taut fascial bands, maybe secondary to tumor or numb chin syndrome or secondary to herpes zoster infection. How to do ultrasound? Now it is also by putting the ultrasound probe transversely and begin downward till reaching a defect, hypoechoic defect within the cortical bone. You see by this picture, there is hyperechoic line, white line, and there is a hypoechoic in the center defect. This is the mental foramen. Now open the color Doppler. You see the vessel. Why we open the color Doppler? To avoid the vascular injury during entering the needle. How to do injection? Also by any plane technique with acute angle. Now we go to auriculotemporal neuralgia. Auriculotemporal nerve, it is a branch of trigeminal nerve. It is leave the trigeminal nerve and enter the parotid gland just posterior to the temporomandibular joint. Usually compressed at this side, sometimes secondary to a tumor of the parotid gland, sometimes post the surgery of temporomandibular joint. It usually accompanies the superficial temporal artery, as give as anatomical landmark to see this auriculotemporal nerve. How to do ultrasound technique? We put the probe, also linear probe, by the sideway of the face, put also transversely at the zygoma. Then you scan posteriorly towards the air until you reach a defect. Sorry, not a defect, until you open the color Doppler to see the artery. This is the anatomical landmark. When we open this color Doppler and see the superficial temporal artery, it is just behind it. How to do injection? By any plane technique, either from anterior to posterior or from posterior to anterior. Now I put just a principle of cryoneurolysis. Cryoneurolysis is, as you know, it is a formation of ice ball at the tip of the probe. What occurs? Rapid expansion of gas, which is N2O or CO2, Joule-Thomson effect, which create a temperature of minus 60, sometimes minus or colder, minus 70, minus 80. The application of cold on the nerve lead to temporary interruption of nerve conduction. So it is very safe procedure, but I think in Iraq not use cryoneurolysis. I see it in India. It is very safe procedure with a very decreasing side effect. How you see by ultrasound when you put a cryoneurolysis, you see after that when make a cryoneurolysis, as by this picture of ultrasound, like ice ball. When you put this, when make a cryo, like ice ball. You see this picture? Okay. Now I begin with pterygopalatine fissure. Why I put here? Because it is also on the same site of maxillary nerve block. This is the defect as by dotted red color. It is the pterygopalatine fissure. This is the defect, a triangular defect. It is bounded anteriorly by the maxilla, posteriorly by the lateral pterygoid plate of sphenoid bone, and medially by the palatine bone. Here is the location of pterygopalatine ganglia. Pterygopalatine ganglia, it is hanging from the maxillary nerve. So you can do also block for this sphenopalatine ganglia as in case of a cluster headache. Now, how to do percutaneous maxillary and mandibular nerve block. First, I talk about the maxillary nerve innervation. It gives innervation to the maxillary sinus. This is the pink color. This is the second one, pink color. It is innervate the maxillary sinus, teeth of the upper jaw, gums, skin of ipsilateral face, upper lip, lower eyelid, hard and soft palate, nasal cavity, pharynx, and the dura mater of medial cranial fossa. I talk about this procedure late just to see the mandibular innervation. It is also innervate the skin of the lower face. If you see by this picture, this is the purple color. Innervate the lower face, cheek, lower lip, anterior part of external ear, part of external acoustic meatus, anterior 2/3 of tongue, mastoid air cells, and teeth of lower jaw. Dr. Shirish speak about the sensory and motor fibers by radio frequency, how to avoid the motor fibers. As you know that the mandibular nerve have a sensory and motor division. So when do radio frequency and do stimulation, if there is stimulation of muscles of mastication, then you should withdraw the needle just at its entry, because at its entry, the motor innervation, this is a maxillary nerve, okay? At its entry, sensory innervation, sensory branch and motor branch. So just withdraw from this foramen ovale, just below it, to avoid this motor damage. Now, ultrasound technique. You see this picture, the first picture, I put the pointer on it. We use now the curvilinear probe, not the linear probe, because it is a low frequency probe with long wavelength. So reaching the deep structure. I put it on zygoma, then I begin to scan downward until reach a defect between two condyle of the mandible, the coronoid process and the condylar process. You see by this picture, I put it through the defect and ask the patient to open the mouth, because when open the mouth, it become wide space to see the deep structure on the pterygopalatine fossa. You see what by this picture, I see when put a probe here, this is the, if we see from anterior to posterior. So this is the posterior, this is the anterior, because I begin, always put the marker to the right side, always put the marker to the right side. So if I put the patient face like here, so the right side is coming posteriorly. This is the posterior, so this is the condylar process, and this is the coronoid process. And here is the bone in another picture, which is lateral pterygoid plate. So this is the pterygopalatine, infratemporal fossa and pterygopalatine fossa. So how to do now maxillary nerve block and mandibular nerve block? You see, this is the coronoid process because it is at the left side. So this is the anterior part, this is the posterior part. This is the fossa. If you come anteriorly, if the needle come to inject in a plane technique, anterior and superiorly, then do the block of maxillary nerve. If we come from anterior to posterior, so to inferior part, so we do sphenopalatine ganglia block. But in the opposite directions, go to block the mandibular nerve. This is explain the supratemporal fossa, and this is the muscle. This is the masseter muscle. Okay, this is the lateral pterygoid muscle. And this is the pterygopalatine fissure through which the pterygopalatine ganglia are available. Now I have a live video, so I stop sharing and share a live video. Is the video appear now?
Yes.
Yes.
Okay, so this is the live video. Okay, I not put the sound of it because you know the sound of the video become not good. So I speak with the video now. So I use a high frequency probe. I begin to scan in the forehead from above downward. Put a lot of gel because it is superficial structure. Continue to scan downward until reaching a hypoechoic defect. Yes, this is the defect. Okay, so I put a diagram for it. This is the nerve, this is the supraorbital nerve, and beside is there is a vessel. And you can do injection by any plane technique. Now I come to the infraorbital nerve. I put the probe sagittal just at the inferior orbital rim. You see, this is the inferior orbital rim as I point, and this is the maxillary bone. Now between them, there is a nerve and a vessel. This is the infraorbital nerve with the vessel beside. How to do injection? Now the needle come by any plane technique, either from above down or from below above. You see? It is just a diagram motion to explain. I explain now to enter either from above downward or from below to above by any plane technique. Not entering the needle too much. It is just at its entry. Now I begin scanning at the mental nerve from above downward, reaching a defect, hypoechoic defect, then opening a Keller Doppler to avoid vascular injury. This is a diagram to explain how the needle enter either from the right side or the left side by any plane. You should see the whole length of the needle. This is the mental nerve. This is the cortical bone of the mental bone of the mandible. And this is the mental nerve with vessel beside. Now I go to auriculotemporal nerve. I put the probe transversely over the zygoma. You see, over the zygoma. Always put the marker toward the right side. continue backward until reaching a vessel. Then the nerve is just behind it. It is auriculotemporal nerve. How to do block? By any plane technique, either from behind, from posterior to anterior, or from anterior to posterior. Now I will change the probe to curvilinear probe, as I said, because there is a deep structure now for maxillary and mandibular nerve block. So we put the probe transversely also in front of the tragus and continue scanning downward to reach the defect between two processes, coronoid and condylar processes. This is the muscle above. If you see, this is the muscle above is the masseter muscle, and this is the lateral pterygoid muscle. This is the lateral pterygoid plate. Now the picture appear wider. And explain by diagram. This is the masseter. This is the lateral pterygoid. If above we go, we see the temporalis muscle. This is the posterior. This is anterior. So posterior, the condylar process, and anterior is the coronoid process. This is the masseter, lateral pterygoid muscle, and lateral pterygoid plate bone. Between us, there is a space which contains the maxillary nerve and sphenopalatine ganglia and the mandibular nerve. Now it is explained by diagram. You see, this is the condylar process. This is the coronoid process. Okay, I pause on this to explain. This is the coronoid process, condylar process. This is posterior, this is anterior. Coronoid, condylar process and coronoid process, and this is the lateral pterygoid plate. This masseter muscle and lateral pterygoid muscle. If we go from posterior to anterior superiorly, then you make a block of maxillary nerve. If you go from posterior to anterior, downward or inferiorly, you go to block the sphenopalatine ganglia. While if you go from anterior to posterior, you do a block of mandibular nerve. So now I stop and return to my lecture. Is my slide visible?
Yes.
Okay. So the logo of this webinar, let's dive, let's learn, let's go and become creative. So at the depth of the sea, you can see this gold. Thank you very much. You can connect to me by phone number or WhatsApp number on Facebook and Instagram, because this recording of this webinar will be downloaded there. And this is my YouTube channel also. Thank you very much. Now I stop my share. Sorry, there is a technical, okay. Now let's welcome Dr. Mahmoud Abdulrahman, who has PhD Pharmaceutical Industry from Pharmacy College, University of Baghdad, has a number of local and international publications. Welcome, Dr. Mahmoud.
Thank you, Dr. Sabah. First of all, I would like to welcome doctors in attendance, and it's my pleasure to join this wonderful lecture with fellow doctors from inside and outside the country. A special welcome to Dr. Sherish, Dr. Khalid, and Dr. Sabah, also the Said company for their support. So I would like to introduce myself. I'm Dr. Mahmoud Abdulrahman, with the Doctor of Philosophy in Pharmaceutical Industry, specialist in nanotechnology and nanocarrier systems. So I hope my lecture will be like the previous lectures, light-hearted and full of useful information. Now I'm sharing my lecture. So is it visible?
Yes, it is visible and you are audible.
Thank you. Now we are going to talk about the role of pharmacological treatment in trigeminal neuralgia, and we see this beautiful lady suffering from pain due to, as explained by Dr. Sherish, due to the trigeminal neuralgia. So the pathophysiology of trigeminal neuralgia and its radiation of pain is belong to the overexcitation of sodium channel that located in this neurons. So there will be an increase of the entry of sodium to this nerves, and increase the action potential will result in a sharp and just like electric shock pain. So according to the American Academy of Neurology and the European Federation of Neurological Societies, it was clear that the first line in treating trigeminal neuralgia is carbamazepine and its generation oxcarbazepine. So they called a frequency-dependent sodium channel blockers. So they have some selectivity for these sodium channels that are dysregulated and overexcited and located in the trigeminal nerve. So they will block the entry of this sodium and decrease the action potential. So based on evidence, the duration of treatment and the doses of these two drugs, the carbamazepine brand name is Tegretol, and the oxcarbazepine brand name is Triloptil, which belong to Novartis, a Swiss brand company. So carbamazepine, the dose will be from 400 to 1,200 milligram per day. This the maximum dose, and for oxcarbazepine will be started from 900 milligram and 1,800 milligram per day. So actually the mechanism or the main mechanism of action for these drugs, they will block the sodium channel in the trigeminal nerve, which result in decrease the action potential and decrease this electrical shock and radiation of pain. The otherwise mechanism of action, they has a little affinity for the gamma aminobutyric acid receptor, which belong to benzodiazepine drugs such as the Valium. So they will increase the entry of a chloride ion to the trigeminal nerve. As we know, the chloride ion has a negative charge. So this will decrease the depolarization and action potential of this nerve, and hence decrease the radiation of pain. Also, they can increase the serotonin concentration in the presynaptic of the neurons, and there are many drugs illustrated by Dr. Khalid, such as the Cymbalta, duloxetine, and the selective serotonin reuptake inhibitors, the escitalopram, which used in the treatment of neuropathic diseases, especially with those suffering from diabetes mellitus. So discontinuation of these drugs may be because of two reasons. Either the patient receiving a high dose of these drugs, but with no any response. So the surgery will be the first choice in their treatment. Or because of adverse events belongs to these drugs, as will be illustrated here. So some patients can't take this medication because of their contraindication. So it was clear that patients with heart disease, such as those taking anticoagulant drugs, such as the warfarin and the epixaban, the main problem is that carbamazepine will attach to and activate a specific an enzyme found in the liver, which is called cytochrome P450, which is responsible for the metabolism and excretion of drugs. So in this case, the carbamazepine will result in a drug interaction and decrease the half-life of these anticoagulant drugs, which may result in lethal side effects because the free interval of free drug in the systemic circulation. So before giving this drug, the patient must be referred to the internal medicine doctor for switching the dose and prevent this drug interaction. Also in patients and in women suffering from osteoporosis and those over 50 years, because of the same induction of the CYP450 enzyme by carbamazepine, there will be an increase in metabolism and excretion of vitamin D, which result in decreased calcium deposition in the bone and result in increased risk of osteoporosis and in the bone fracture. Also, a fall, there will be a fall in blood elements, so such as the white cells, red blood cells, and platelets. So patients, those taking the carbamazepine, and they take at least for 3 months to 6 months for the treatment of the trigeminal neuralgia and may last for years. So they must undergo a complete blood count every 3 to 4 months. Also, it causes a hyponatremia, as explained by Dr. Shirish, which is widely common with this drug. The main cause is its induction of the ADH, which result in decreased urine volume and increase the osmolality, which result in increase the sodium ion in the urine, which cause hyponatremia in the blood circulation. So also it induces a central nervous system depression, which the main cause is due to its block of the sodium channels in the neurons in the central nervous system, which result in confusion, imbalance, and somnolence. So in this study, there is a comparison between the carbamazepine and oxcarbazepine, which is the newest generation of carbamazepine. So 200 patients divided into 100 patients received the carbamazepine, and also a 100 patient received oxcarbazepine. We see that the carbamazepine side effect have a sharp peak rather than the oxcarbazepine. So totally the author first line chose is oxcarbazepine because of its better tolerability. While the main serious side effect that may caused by carbazepine, its induction to Stevens-Johnson syndrome and its related disease, which is the toxic epidermal necrolysis. So this disease seriously occurred due to a specific allele which called HLA-B1502, which is found in the T cells of the immune system. So the carbamazepine will attach to these allele and cause overactivation of the T cells. This overactivation will result in a toxic allergic reaction, and we see in this picture the rash found in this patient who took carbamazepine, and here is the necrolysis because of the allergic or toxic allergic reaction. So this allele is found in the South Asia more than Caucasian people. So in Malaysia and in Thailand and India, the red line. So people suffer from about this allele mutation is about 13%. So to overcome these side effects with carbamazepine, there is a new test which called the pharmacogenomic test. This test nowadays it's sold in the pharmacies of the USA, Canada, Australia for screening any mutation or this allele in patients. Now this picture is for this kit. So the patient may go to the pharmacy and ask for a pharmacogenomic test. So the pharmacist will take a saliva and from the patient, and after 10 days, the results can be illustrated by the pharmacist to the patient. So if there was any mutation or there is no found of this allele, so the patient can take the medicine, while if there is any mutation, so it will be referred from the pharmacist to the doctor to switch or change the drug because of this mutation. So in these countries in South Asia nowadays, it's usually there is a pre-counseling between the patient and the doctor for pharmacogenomic test. They will take a blood sample for screening of HLA-B. After that, if the test positively, so there will be a post-counseling between the patient and the doctor, and the patient will given a specific card which contain the name of the patient and its age, and which contain of a mutation or this allele, which is called the HLA-B gene. While the nightmare scenario, there is no pre-counseling between the patient and the doctor after admission. This patient with a trigeminal neuralgia, so there was no pre-counseling between the doctor and the patient. They asked for a blood test. The test was positively for HLA-B. So in this case, there was no post-counseling between the doctor and the patient. So the patient, and they don't have this specific card for this gene. So this doctor or another doctor may prescribe carbamazepine drug. So the patient will take the drug in home, will suffer from an allergy, and it will continue to, and he will continue to take the medication and might severely be ill and could die because of the Stevens-Johnson syndrome and its related diseases. As we explained before, the first line for the treatment of trigeminal neuralgia is the carbamazepine and oxcarbazepine. So if the patient was respond for this drug, we will monitor for these adverse events such as any anemia or hyponatremia or any allergic dermatitis, or the patient not respond or can't take the full dose of carbamazepine or oxcarbazepine because of contraindications. So the dose will be decreased, and we can add another drug such as the lamotrigine. So if there was the adverse effect or there was no response, so we can depend on the botulinum toxin before their surgery. And if there was no response, so the surgery will be the last choice as prescribed by doctors previously, which belongs to gamma knife and other procedures. So in talking about recent strategies in treating trigeminal neuralgia is the smart drug delivery system. These systems, they are deliver the drug to the main target site, and they call the smart because they will be activated by the specific temperature of that organ or specific pH. So it will reduce drug toxicity and side effects because of the spreading of drug in systemic circulation, and it will improve the therapeutic efficacy. So an example of this smart drug delivery system, this paper was published in 2022 for the delivery of carbamazepine directly from the nose to the brain by preparing it as in situ gel. So as we know, carbamazepine has many side effects and issues because of its low aqueous solubility. This will decrease its absorption from the gastrointestinal system, and it's bypass the blood-brain barrier and its narrow therapeutic window. So we can prepare it by intranasally directed to the nose as in situ gel. Here we see in situ gelling thermosensitive. The difference between the in situ gel and gel, at which that the in situ gel will be a liquid at room temperature, while after being in the nasal cavity, it will convert it to a gel by the action of the temperature of the nose, which is 32.3 degrees centigrade, and provide a mucoadhesive. So there will be a control release for the drug, which directly go to the brain by two pathways. The first pathway is by the olfactory neurons and directly bypass the blood-brain barrier, while the second pathway and what we're looking for the treatment of trigeminal neuralgia, it will go directly to the trigeminal nerve and absorbed in high value in this nerve, and will directly act on the sodium channels that in the sodium channels that found in this nerve and regulated it. So in this picture we see the matrix. Here are the blue colored, and the drug is entrapped in these white circles. So the drug will be released in a controlled manner that will reduce the systemic side effects belong for carbamazepine and increase patient compliance. The good things also, there is a newly discovered drug which called the vixotrigine, which is a selective peripheral sodium 1.7 blockers. These sodium channels are highly localized in the trigeminal nerve. So in 2018, it entered the phase 3 in a clinical trial, which mean in phase 3, the clinical trial bypassed the laboratory and the animals, and it success. So now it's we are monitoring about its safety and effectiveness and its advantages of the drugs in human. This made by taking a collection of 300 to 3,000 of patients taking this drug. This will take about 8 years. After that, there will be an approval by the FDA if the drug was effective and with low side effects. So this drug undergo a chemical modification to targeting the peripheral sodium channel. So the sodium channel and the drug is in the yellow color. So after the binding of the drug to the sodium channel, there was a shifting in the sodium peak, the action potential, which caused the sharp pain and electric shock. So there was a shifting in the action potential peak, while before taking this medication, look how the peak was sharp. So I think about in about 4 to 5 years, the drug will be approved and will be marketed. Thank you for your listening, and thank you for your attention.